The next disorder I would like to talk about is bipolar disorder. Bipolar disorder is a mood disorder. As you can see, you can run in a spectrum from severe mania to mild to moderate mania to hypomania to normal mood, then mild depression to severe depressions. Hypomania is usually mild compared to manic features. So usually they should not have psychotic symptoms, and they usually doesn't cause much impairment in the functions of the patients. Hypomania the minimum requirement be 4 days, while mania the requirement be 7 days. The hypomania usually based on textbook or diagnostic criteria, it should not be that severe. But in clinical practice, we do find that hypomania, although it may not be that severe, but and it's also more difficult to diagnose because the patient maybe even be viewed as having a personality issue. But it turned out because of it was delay in diagnosis and the patient still functioning. So the damage can actually can be great. I have cases that a patient with hypomania and cause a whole family to slowly to go into bankruptcy because of the minor overspending and poor judgment in investment. The difference between bipolar disorder and unipolar disorder is that the genetic factor may play a more key role in bipolar disorder than unipolar disorder, and the preference in bipolar disorder is the general preference is 1 to 1 is equal to 1 to 1. The core features of mania, as I mentioned before, there may be elevation of mood, irritability, increase in energy levels, psychomotor activations, and there's a reduction of sleep, there's a poor judgment, and the patient may require, many may have 1 week or longer in durations. The treatment for bipolar disorder, first-line treatment is still remain lithium, although sodium valproate is also getting very common nowadays in clinical practice. Lithium is a quite effective drug if the patient use it properly. The concern is if patient overdose on the lithium, it can be toxic to the kidney. We do check plasma lithium level is between 0.6 to 1.2. The ultimate is around 0.8. Lithium also have an antidepressant effect. If you use it properly, actually it can reduce suicide risk by taking lithium. Lithium have a very low therapeutic index, so it can be dangerous. The side effect of lithium, usually it can cause a dry mouth, polyuria, it can cause some polydipsia, it can cause some minor tremor, it may cause some headache and some GI side effect. But when in the long-term side effect, patient may develop hypothyroidism and renal problem, kidney failure. So that's why we have to check lithium every 6 months to make sure they don't develop any kidney problem or any thyroid problems. You may need to know that when patient overdose on lithium, the symptoms may include in the beginning they may have gastroenteritis, then slowly they will move on to be having very cross tremor. They may have ataxia. They may develop confusions and then coma. The treatment for acute lithium intoxication is by dialysis. When a fetus, if you know someone is pregnant and then they take lithium, what happened to the heart of the fetus? It will lead to what we call Epstein abnormality. It's a heart defect. You have a atrial septal defect, and then you also have the abnormality of tricuspid valve, but it only affects 1 in 1,000 fetus. So the decision is that do we actually must stop the lithium during pregnancy? The answer is have to use a risk and benefit ratio. It's not 100% the fetus will develop Epstein abnormality, but we also look at the impact on the mother without the lithium. If the mother really needs the lithium, we may have no choice, and then have to, because of the risk of severe relapse, we have to continue the lithium during the pregnancy. The next mood stabilizer we use is valproate, sodium valproate. Sodium valproate it does not affect the kidney and the thyroid, but it affects the liver. So we must do a liver function test before we start the sodium valproate. Common side effects including weight gain, cognitive impairment, and it's quite effective in maintenance. And the other thing is there's a bipolar disorder called rapid cycling bipolar disorder, which the patient have at least 4 mood episodes per year, and lithium is not effective in rapid cycling mood disorder, so we have to treat by sodium valproate. One common side effect I see in my patient is that they complain of hair loss after taking the valproate, and the other common side effect is weight gain. As I mentioned before, it can cause a fatal hepatotoxicity, and liver function test is a must. Carbamazepine is also a second-line mood stabilizer we use after maybe sodium valproate and lithium. But carbamazepine, one of the problems is that nowadays we need to order genetic test to prevent the patient developing Stevens-Johnson syndromes or severe rash. And that genetic test can be quite costly, and actually it's also cause a lot of inconvenience. Patients have to wait for genetic result before we can start on carbamazepine. So now the usage of carbamazepine has reduced. In the past, we commonly use carbamazepine because it has minimal side effect on weight gain, but we have to take note that carbamazepine is a drug inducer, so it can reduce the effectiveness of other drugs and medications. Lamotrigine is commonly used in bipolar depressions. It has one common side effect is a Stevens-Johnson syndrome. We'll quickly touch on perinatal psychiatry. When a mother gives birth to a baby, in the first few days they may have a postnatal boost. It may last for a few days. It's just occurring 50% of the mother. It does not require treatment. Postnatal depression occurs in 10% of the cases. Postnatal depression is quite psychosocial, so it can be caused by family history of depressions or past history of depressions, but this can be caused by like poor relationship with the husband, very poor social support, and difference towards the pregnancy. Postnatal psychosis, postpartum psychosis is much more rare. It occurs about 0.5%. You can see the psychotic phenomenon and the manic features, and also cognitive impairment and confusion is quite common in postpartum psychosis. So it's not just psychosis, but you have to look at for the manic features and also disorientation confusions. Risk assessment is important in postnatal depression and postpartum psychosis because the mother may have thoughts of harming the baby.